Josie and I were co-residents, in fact, and she then went on to the University of Southern California, where she worked with Dr. Eric Kazarian, who's a world leader in the area of sleep apnea surgery, and really helped to bring the technique of drug-induced sleep endoscopy to the forefront of the field of sleep surgery. So Josie spent her fellowship there, training in sleep medicine and sleep surgery. And we're very fortunate to have her back in the Toronto area, practicing at North York General Hospital, where she has a practice in general otolaryngology, but a special focus and interest in sleep apnea surgery. So she'll be, we'll be delighted to hear from her about patient and soft tissue procedure selection today. All right, and you're off.
Great, Mike. Thank you so much for the invitation. I mean, as I mentioned before, hopefully this is a bit of a two-way conversation. I'm really excited to learn more about, the practice of sleep medicine in Ontario, but especially with Peak and how you guys have built this amazing multidisciplinary team, which I think is really what is missing with care for sleep medicine and obstructive sleep apnea patients in Ontario. So, I'll try to give a brief overview of what I've learned through fellowship and through practice so far. You have an expert amongst you, with Dr. Michael Awad, but, we'll hopefully get into some discussions about these topics. So our objectives for today: discuss the soft tissue surgical workup of obstructive sleep apnea patients, introduce the role of drug-induced sleep endoscopy, and also highlight some of the modern surgical techniques for patients with obstructive sleep apnea. So the topic itself, of course, doesn't need an introduction. You're all familiar with patients with obstructive sleep apnea and the pauses in breathing and the way that we categorize them into mild, moderate, and severe. Specifically, although there's many different reasons why someone can have obstructive sleep apnea, the most important component, to at least my perspective as a surgeon, is the anatomy. And so where are they having blockage in their airway? Is it something that's more related to the soft tissue or about the skeletal bony enclosure? So is it something where they have more soft tissue, for example, in obesity, where they have then a smaller airway, or do they have a small maxilla or mandible, then with an even normal amount of soft tissue, they can have a very restricted airway, and this can come in many forms. And as I mentioned, we all know that the pathophysiology of obstructive sleep apnea is multifactorial, but anatomy makes such a big component to it, in addition to reduced upper airway muscle function, low respiratory arousal thresholds, and high loop gain. And these are areas, that I'm not as much of an expert on, and why we need to continue to work together, with my sleep medicine colleagues to see how each patient is impacted by the many facets of OSA. So OSA management, I am certainly not a surgeon who's here to say that surgery is going to fix everything. Actually, quite the contrary. I really do believe that all patients need to have a very thorough trial of lifestyle changes and CPAP prior to discussion about, whether alternatives are reasonable for them. And so I do believe that CPAP therapy, other than conservative management, should be first-line therapy for these patients. Though you've all seen the major problem with CPAP intolerance, and so there's a plethora of reasons why patients might not be able to tolerate their CPAP in the long term, whether it's a mask fit problem, whether it's aerophagia and air pressure, whether it's nasal obstruction, and what are the different ways that we can treat nasal obstruction, either medically or surgically. Or maybe the patient just doesn't believe that they'll be able to tolerate CPAP or persist with it. Maybe it's a question of claustrophobia or unconscious removal at night, all of which leads to an inability to keep CPAP for a long term. And of course, there's other, non-physical tolerance reasons that we talk about, whether it's cost or patients just don't feel motivated, whether it disturbs the bed partners, et cetera. And so although we hope that patients will do well with CPAP and live happily ever after, unfortunately, that is certainly not the case. We know that CPAP intolerance rates are upwards of 30%. From some general estimates, there is a StatsCan survey that said that approximately 6% of Ontarians have diagnosed obstructive sleep apnea. Now, if there's almost 12 million Ontarians and 700,000 are diagnosed with OSA, then we take into account the intolerance rate. There's probably over 200,000 Ontarians that are intolerant of CPAP in the community, untreated, and certainly at risk of developing complications or having symptoms of obstructive sleep apnea. This is one of the reasons why I became so interested in this area and wanted to think about whether alternatives might be available for this patient population. And so the management pathway is familiar to all of you. OSA might be suspected, then diagnosed by sleep medicine lab. CPAP might be prescribed. If it's great, then that's wonderful. Hopefully the patient can continue. But if the CPAP is not successful, then hopefully they can get some troubleshooting. Why can we, is there a way that we can get this to work? Or perhaps they can get an oral appliance referral to some of our dental professional colleagues. But more often than not, I definitely hear of patients who are lost to follow-up. They are floating around again in the community, not really sure what to do. They didn't do well with their CPAP. They don't have follow-up with their sleep medicine team. And, this becomes an afterthought on their medical history. And so I'm hoping, again, with working with groups like yours, that we can increase the awareness of the options in terms of surgery, whether it's from an otolaryngology perspective or maxillofacial perspective, both with sleep medicine and our primary care colleagues. And so you're familiar with traditional sleep apnea surgeries, and this can range from surgeries kind of targeting the nose and the nasal airway, for example, a septoplasty for a deviated septum, or inferior turbinate reduction for enlarged turbinates, or an adenoidectomy, particularly in children when the adenoids are enlarged, especially when they're in their younger years, less than 10 years old. And then we move to the palate or the VELUM or an oral pharynx. So a tonsillectomy, certainly very commonly done again in children or in adults who have large tonsils, and uvulectomy or laser-assisted uvulopalatoplasty, plus the notorious UPPP or uvulopalatopharyngoplasty, very popular a couple decades ago, very in vogue. And, we're still seeing some of these patients now, which perhaps, they didn't have the best outcomes in the long term. Most drastic, of course, is a tracheostomy for patients who might need to uncap their tracheostomy at night due to severe complications of obstructive sleep apnea. So, there have been many ideas with how to treat sleep apnea with surgery. And previously, there has been more of a severity-based approach in terms of procedure selection. And so when we think about the spectrum of primary snoring to mild OSA to moderate OSA to severe OSA, at one point it was thought, well, if it's primary OSA, then maybe we can just focus on fixing the nose, or maybe we can just cut off the uvula because it, doesn't really seem like that big of a problem if it's just snoring. Or if it's mild or moderate, maybe we can do a UPPP and that'll help it. Or perhaps if it's severe OSA, we could just hit them with all the surgeries. We'll do all the surgeries because the patient has severe OSA. But over time, we have learned more and more that the severity of OSA does not necessarily correlate with those specific levels of obstruction, but that you can have primary snoring at all different levels of obstruction. You can have mild OSA from all different levels of obstruction, and same with moderate or severe OSA. So instead of picking a procedure just based on the severity of the OSA, then we think more about an anatomy-based procedure selection. We think about where in the upper airway the patient might have obstruction and try to correlate our procedure to be directed specifically in that area. So in addition to some of the previous procedures that are available, new techniques have been developed. There's been many variations. There's been new technology that is developed. Especially exciting is coblation technology, and of course, improvements in surgery such as the maxillomandibular advancement, which I won't be able to touch on today. So specifically, I wanted to introduce how I think about patients and what I do for patients when they get referred to me. So this is my general workup. So again, I really start with that detailed history and review of the sleep study. I make sure that they've tried the different conservative options. We've talked about the risks and benefits, and also talking about CPAP, and specifically, why didn't CPAP work for them? Was it more of a pressure problem? Was it more of a nasal obstruction problem? Was it more of a mask fit? Could they have done more troubleshooting, or did they buy the CPAP themselves, or try to do the best they can and weren't actually able to see a appropriate, well-trained vendor for that? I really make sure that we think about those things first, and then I move on to the physical examination. So in the physical examination for OSA, you're familiar with how the body mass index makes such a massive impact on the prevalence, or the I guess the just having obstructive sleep apnea in general, but it really makes a big difference on how we think about these patients as surgical candidates as well. When patients have a higher BMI, they're more likely to have their fat deposited both in their tongue and also in their lateral pharyngeal walls, and this traditionally makes it much more difficult to do targeted surgery. For this reason, I do limit the amount of pharyngeal surgery that I offer to patients who have a BMI over 35 due to the risk of complication and due to the risk of it not being as helpful. And it's not just fat either. I mean, lateral wall hypertrophy, especially in our more muscular patients, certainly in Los Angeles, I saw a lot of very muscular patients who wouldn't be thought of as, you know, on a BMI scale, they are overweight, but you look at them, they're not the typical obese, you know, patient with sleep apnea. Even though they're fit, in good shape, they have significant lateral wall hypertrophy, which causes significant obstructive sleep apnea, often difficult to treat surgically. We look at the neck, and we know how neck circumference can be predictive, but specifically we also look at how much submental fat someone might carry. Perhaps there's someone who carries less fat under their chin, or rather, and how that impacts their upper airway. And specifically mandibular insufficiency, how does a small or retrognathic mandible affect how I look at their structure? How might this impact hypopharyngeal obstruction? And specifically, these patients with these bigger beards sometimes might be hiding a smaller or more retrognathic chin. And so something I always try to point out to the learners to make sure you look behind the beard. The nose. So moving on to the nose, very important in our evaluation. And so looking externally, of course, to see, are they someone just with a narrow nose at baseline, or do they have a more dynamic nasal valve collapse? Here in the corner, you see a video of someone who is inhaling and has significant lateral wall collapse. Very different reason for nasal obstruction than a septoplasty. The caudal maneuver is where you're able to move part of the skin to see if opening up that region allows more airflow. Anterior rhinoscopy, I mean, these are tools that we're getting into kind of more specifically available to just otolaryngologists, but we want to look inside to see if we see obvious septal deviation. We want to look at the quality of the nasal mucosa. On the right here, we have a more normal nasal endoscopy view with a smaller inferior turbinate. There's in the middle. This can be a picture of someone who has mucosal hypertrophy or perhaps allergies that might be able to be just medically treated rather than surgically treated first. Tonsil size, we grade tonsil sizes. We know that the tonsil size can make a major difference if we can remove them surgically, even with patients with large BMI as well, depending on their palate position. Again, looking at the oral cavity, we look specifically at the soft palate, at the uvula. How thick is it? Is it very redundant? How much retropalatal space is there behind the posterior pharyngeal walls, which are the arches, the soft tissue arches that you see here? How big is the tongue? Does the tongue, and so I'm sorry, here are some pictures where it's, you know, very difficult to look into the oral pharynx, or you can see that the palate is very posteriorly displaced. Perhaps these are patients who have some scarring after a previous UPPP, or you know, you see ridges on the side of the tongue that indicate that their tongue is large relative to the size of their mandible. And looking, of course, at the palate and tongue position as described by the Freeman tongue position or modified Mallampati score, and you know, giving us a gestalt of what their oral cavity looks like. They also do you know, their cursory exam of their dental skeletal arrangement, and what is their angles classification look like, and is there evidence of retrognathia, or is there mandibular torus that might again give us more evidence that they might have hypopharyngeal obstruction, even just by looking at them in front of us in the clinic. So then we perform an awake fiber optic nasolaryngoscopy. Hopefully this video starts to go. I'm getting my swirling cursor, which means that it's loading slowly. So specifically, the fiber optic nasolaryngoscopy allows us to see into the nasal cavity, into the posterior nasopharynx, then down into the oropharynx and the hypopharynx. And I'll point out that we're looking specifically at the retropalatal space and the retrolingual space, which you can see in this sagittal view of the diagram here. So in the video right now, we're going into the nasopharynx and looking down into the oropharynx. You can see the uvula in the midline. And if we skip ahead a little farther, then you can see the hypopharyngeal region with the epiglottis in view, and the back of the tongue base there in view as well. So specifically on our scope, I do definitely pay attention to the lingual tonsil, which is a specific structure at the back of the tongue base. So not necessarily part of the tongue, but similar in composition to the palatine tonsils that we can see through the mouth, but specifically called lingual tonsils. And we grade them on a scale. Specifically, if these are large, then we can think about certain surgical procedures to treat that. We can also gain information from the epiglottis position or shape. There is some literature out there that describes how the actual shape of the epiglottis might give us clues as to the closure pattern of the pharynx. And so when you look at an epiglottis, which is more V-shaped, perhaps there's more lateral wall closure in this patient versus something, this is described as the normal position, or an epiglottis, which is more flat, which may show perhaps this patient has more hypopharyngeal or tongue base obstruction that is causing more anterior posterior collapse. So in our evaluation, we've done a complete head and neck examination. We do flexible endoscopy. However, it's not fully representative of the asleep airway because the patient is sitting upright, the patient is awake, and the patient is protecting their airway. This is completely different than when they are asleep and supine at home. So this is where drug-induced sleep endoscopy can potentially give us some more information. Drug-induced sleep endoscopy was first described for adults in 1991, and effectively it's an upper airway endoscopic examination under sedation. So the same flexible fiber optic nasolaryngoscope is used as when the patient is awake, but the patient is put in a medicated sleep. And the goal is to identify the area of upper airway obstruction in the upper airway. Specifically, I like to use drug-induced sleep endoscopy for adults who are surgical candidates, but it's unclear where the area of obstruction might be, and specifically in patients who have a BMI of less than 35, because these patients I'm already thinking about whether or not I want to do surgery. And so if it's already obvious in their clinical examination, I may bypass this, but this is for patients where it's less obvious. My general protocol is that patients, I do this in North York General Hospital in the operating room, and patients receive some glycopyrrolate to reduce some of their secretions. They receive a nasal decongestant to reduce the edema inside their nasal cavity, and also topical anesthetic so they don't feel the endoscope when they're drifting off into sleep. No other pre-op sedatives are given to the patient. We then mimic the sleep environment. We turn off the lights, we give them some pillows. We start with them lying on the side. The weirdest thing for the patient, of course, is that they have all these people who are watching them sleep. But as we continue to increase their propofol infusion, we titrate it slowly until they reach a target sedation, which is often when they're snoring or when they're showing signs of obstruction. At that point, I perform the scope with visualization similar to this picture in the upper corner. We do it both in the lateral position and also in the supine position, since there's such major differences in certain patients in terms of positioning and how severely and where they are obstructing. We also will do some special maneuvers to see how that impacts the airway. After I'm done, the anesthesiologist will provide airway support as much as needed. The patient will wake up. Oftentimes they're awake and talking to us, fully alert in the operating room before we even go to the recovery room. And as long as patients are well the same day, they go home. And so usually just a couple of hours in the hospital setting for these patients. We then grade the drug-induced sleep endoscopy using what we call the VOTE classification system, and VOTE stands for the VELUM, oropharynx, tongue base, and epiglottis. We score each region out of a 0, 1, or 2 as no obstruction, partial obstruction, or complete obstruction, and we identify what type of configuration it was, whether it's an anterior-posterior configuration, a lateral wall configuration, or more of a concentric closure. So here are just some videos of what we see during drug-induced sleep endoscopy. This is at the level of the soft palate. Hopefully you can hear a little bit of snoring as well. This we would classify as complete circumferential collapse. Here's an example of partial anterior-posterior closure. So just to orient, we have the uvula at the bottom here, the posterior pharyngeal wall up top. So you can see that there's far more closure just between the anterior and posterior walls and far less involvement from the lateral walls compared to the concentric closure that we saw previously, even though it was at the same location. Here's an example of complete lateral collapse when the lateral walls of the oropharynx are completely coming in from both the left and right sides. Here's just a picture, a static example of how a significant lingual tonsil hypertrophy at the back of the tongue base can really push back the epiglottis here, as opposed to isolated epiglottic collapse. From this video, you can see that the epiglottis itself is falling all the way back by itself, even though the tongue base is not moving as much. Let's just play that again just to see. And so we really spend time during the drug-induced sleep endoscopy to differentiate the different levels and how much they are obstructing to give us more information about what we want to do surgically. Now, the special maneuvers I talked about, one is a mouth closure. So if the patient has their mouth open the whole time, just closing their mouth can make a big difference in the orientation of their pharynx, and that can give us more information on what might happen if we can treat their nose and get them to be less prominent mouth breathers. And also we try to mimic the effect of an oral appliance just by giving the patient a little bit of a jaw thrust while the endoscopy is happening. So you can see here in this video, you can see significant lateral collapse when the patient is relaxed. But when we give a little bit of a jaw thrust, emulating what an oral appliance might do, we see that the airway is much more stabilized, with much less lateral pharyngeal collapse. But the big question really is, does drug-induced sleep endoscopy predict the surgical outcome? And so there have been many studies on this, and it's quite a difficult thing to study, given that you can't really randomize patients to these procedures at this point. But this is a large multi-center trial that was conducted out of the University of Southern California. They looked at 275 patients who underwent pharyngeal surgery, and specifically, these patients did not have tonsillar hypertrophy. So these patients are much more difficult to try and kind of guess, what surgery might best suit them. Using the definition of surgical success as the post-op AHI of less than 50% of the original and absolute number of less than 15, they came up with these results. They found that any patients with oropharyngeal lateral wall obstruction, any degree of obstruction, so whether partial or complete, had a 51% decreased odds of success. Whereas the tongue obstruction, if the patient had complete tongue obstruction, that there is over 50% chance decreased odds of success in these patients after pharyngeal surgery. And although it doesn't exactly tell us which surgery might be best for these patients, the drug-induced sleep endoscopy can certainly provide us information on who not to operate on, which I definitely feel is equally as important as who we should operate on, because we certainly don't want to be operating on people who don't see a benefit, but might still have to go through the recovery period and potentially complications of surgery. So in summary, this is what my sleep surgery workup looks like. And so we do the history, sleep study. We make sure that we exhaust conservative options in CPAP. We do the physical examination. And if there's no obvious sites of obstruction, then we think about doing the drug-induced sleep endoscopy. And once we've decided that surgery is something the patient is interested in, then from their level of obstruction, we think about what type of surgery at what level might suit them best. So nasal surgery, the goals of nasal surgery are to increase the nasal airway and to decrease mouth breathing. Now, if the patient is mouth breathing, their tongue and their jaw are more likely to fall backwards and obstruct the airway. So, decreasing mouth breathing in any way definitely can be helpful for the patient. And of course, there's a great role in increasing CPAP tolerance, and this applies to patients of any BMI. And so a lot of the time I tell patients, they come in, they want to have surgery for their nose and get rid of their CPAP, but really I say, the goal really is to improve their tolerance with your CPAP. The CPAP is probably the best thing to help you. And so this is a more realistic goal. And so for these patients, we talk about septoplasty, inferior turbinate reduction, or a septorhinoplasty if that's more suitable for them. Now we know that nasal surgery is not there, known to not completely reduce the AHI, especially to levels less than 5, but there are, meta-analyses that now show there's significant improvements in the Epworth Sleepiness Scale and the RDI, which for some patients, especially in the mild to moderate category of OSA, I argue, is just as important as reducing the absolute number of apneas and hypopneas. There are modern techniques for uvulopalatal pharyngoplasty, so different than what was described and performed a few decades ago. Specifically, the expansion sphincter pharyngoplasty is a very commonly used technique. There's less total resection of the soft palate and the uvula. So previously they just kind of resected the whole soft palate and it caused some scarring. So now there's less resection and more suspension of the tissues. We start with a tonsillectomy. We then dissect the palatopharyngeus muscle, which is here, and then we suspend them, we dissect them off like this, and then we suspend them in a superior lateral direction to open up the posterior pharyngeal airspace. And we also only shorten the uvula if needed. We know that cutting off the uvula is not necessary in some patients who don't have a necessarily large uvula, but it can cause disruptive globus sensation. And the outcome data is good. And so after 6 months in the short term, in comparison to a traditional UPPP technique, the expansion sphincter pharyngoplasty had improvement in their AHI. In the long term, the data is still lacking. I think, during my fellowship and speaking with Dr. Kazarian, he definitely had good results for these patients as long as they didn't gain weight. And so, we know that the expansion sphincter pharyngoplasty can definitely perform better than UPPP in the long term as long as the BMI is stable. We know that it can also reduce the Epworth Sleepiness Score, and certainly there are still complications after the surgery, but patients' main complaint after the surgery is usually the post-operative pain and recovery rather than persistent complications, which more often than not will dissipate. So here's just an example of a patient intra or pre-operatively, right before we operated on them. You can see they have significant webbing of the posterior pillars. There's really not a lot of space between the posterior pharyngeal wall and the posterior pillars here. This patient had severe non-positional OSA with an AHI of 61. So a patient was really quite symptomatic and difficult to tolerate any other sort of alternatives. Immediately post-operatively, there's definitely some edema here, but the palatopharyngeus muscle was suspended laterally. You can already see that there's a significant increase in retropalatal space. At 3 months post-op, the patient reported improvement in sleep quality, and on repeat PSG, they still had some moderate OSA, but it was much more positional. And so when the patient was able to stay in a non-supine position, which he was actually able to do, his numbers were significantly improved. So if the patient has lingual tonsil hypertrophy, as I alluded to before, I'm excited to offer coblation lingual tonsillectomy and midline glossectomy. So instead of traditional techniques with monopolar cautery, which is at much higher temperatures and cause a lot more airway swelling, or the patient needs to stay in ICU afterwards, coblation can be used, which uses low temperature to decrease the tissue that is in that area. And so here's just, an example of what it looks like intraoperatively. We basically go in with the coblation and take down a lot of the tissue. It looks a little bit messy at the end of the surgery, but at post-op, the patients recover quite well and certainly have a much more patent airway than they did previously compared to the first. Another use of coablation is what we call radiofrequency ablation. And so this is quite a minimally invasive and much more easier to tolerate procedure than some of the other procedures we offer. Ideally, the goal effectively is to create scar lesions in the tongue itself to reduce tongue laxity when the patient is lying supine. And so we treat multiple sites. And so, for example, when the probe is inserted and it creates scar tissue, similar to this image that we see here. And so when we place the probe and create the scar tissue in multiple areas, the thought is that the tongue will prolapse less frequently. When compared to CPAP in placebo-controlled randomized controlled trials, it showed that it was similar to CPAP in reducing sleepiness and improving quality of life. So there is good evidence as well. Genioglossus advancement is an interesting procedure where we try to capture the genial tubercle, where the belly of the genioglossus muscle, which is the main component of the tongue, is attached, and we bring this genial tubercle forward to bring the base of tongue anterior as well to create more space. HYOID suspension is a specific procedure which we make an incision through the anterior aspect of the neck. We bring the hyoid bone down towards the thyroid cartilage because there's a specific ligament that attaches between the epiglottis and the hyoid. And so with patients with specific epiglottis collapse, we may offer this to reduce the amount that the epiglottis is collapsing in the airway. And so that, concludes my part about the different surgeries that I will be offering these patients. And, I just want to finish on a note to discuss multidisciplinary care of OSA. And I think this is where Peak Sleep, is ahead of the rest of the groups that are in the province in terms of servicing these patients. We know that obstructive sleep apnea is treated by so many different physicians, dentists, maxillofacial surgery, our CPAP vendors, bariatric surgery, and they all work together ideally, but the method of communication or collaboration is not always straightforward for these clinicians, and the patients often get lost kind of in the middle, trying to figure out where they should go next. And so in the management pathway, I'm really hopeful, again, to increase the awareness of the surgical options that are available for these patients, especially when they can't tolerate CPAP or they can't tolerate oral appliance. And so, I'm not here to say that surgery is better than any other modality, but for the patients, especially who can't tolerate anything else, I think it's our duty to try and give them at least another option that they can consider and to figure out whether it might be a good option for them. You may be familiar that the American Academy of Sleep Medicine specifically put out a guideline talking about the referral of patients with OSA who are intolerant of CPAP, that they should all be receiving a surgical consultation. So thankfully, the AASM agrees with this thought as well. Management of OSA with oral appliance and skeletal surgery is outside of the scope of this talk. And again, thankfully, you guys have some great people on staff there. I would love to learn more about how you guys manage these patients. And but all of these modalities really work together. And so even if the patient does have surgery, certainly I'm looking forward to working with a sleep medicine group to talk about how the patient still needs to be, really titrated to figure out something that works best for them. Surgery is often not the end of the end of the rope for them, and sometimes they still might need CPAP or additional modalities. And so this is why I think multidisciplinary care is so important. Certainly, there are many challenges in the realm of surgical OSA. Collaborating and coordinating with other sleep professionals is important. Need for more high quality research on patient and procedure selection is very difficult. We need more funding for certain procedures and technology. Now, the hypoglossal nerve stimulator is a very exciting technology that is not available in Canada just yet. And we are excited to get more otolaryngologists excited about the field of sleep surgery so that more people can be offered these different alternatives. So in conclusion, I do think that OSA patients intolerant of CPAP should receive a surgical consultation, and that modern soft tissue surgery is much more personalized, it's much more anatomy focused, and even more conservative than prior procedures. I really do think that multidisciplinary is key for providing good care. So thank you again for the opportunity to speak with you. And, this is just the tip of the iceberg on this topic, of course, and I'd be happy to take any questions. I am seeing these patients primarily out of North York General Hospital and a private office associated with them. I've attached here my email, and if you want my contact information, my phone number, I'm happy to provide that as well. And back to you guys, hoping to learn more about what your group does.
Great. Josie, thanks for a great talk. This is really, really helpful, especially for our group, as you being one of the first providers in the area who's going to offer these modern soft tissue approaches. I think there's definitely going to be a number of questions. I would say if there's one key takeaway for our sleep specialists, it's really going to be, nasal surgery and the role of nasal surgery in aiding their CPAP compliance. So I think there's this common misconception that you send a patient to an ENT or a sleep surgeon, and that's kind of the end of them. They're going to be hacked up one way or another, and you may never see them again. But actually, there's this very close collaboration between an ENT surgeon, especially one with your type of expertise, and a sleep specialist. We know that up to 25% of patients who have obstructive sleep apnea will have concurrent nasal obstruction that may not be seen on anterior rhinoscopy. And so those patients who have concurrent nasal obstruction and don't tolerate CPAP, based on the large-scale meta-analyses that we have, will ultimately benefit from improved CPAP compliance, as you mentioned. And in these large-scale meta-analyses, we've seen that up to 90% of patients who were not tolerant of CPAP before and had concurrent nasal obstruction are able to then tolerate CPAP with the second trial. So I think that's a huge takeaway from your talk today for everybody, who is practicing with us, to really think about nasal obstruction is a key. Much to the bemoaning of our patients, I have our patients fill out quite a few intake forms on the night of their study, and one that we've added is the nose or nasal obstruction score. So if you see those in the patient charts, typically a nasal obstruction score of 50 or out of 100 or above is something that maybe you should be probing about nasal obstruction and thinking about. But that would be my key takeaway listening to your talk today, that you can easily incorporate into your practice from here on out. But looking forward to hearing the questions and comments and discussion here.
Just wanted to touch briefly on that. I totally agree with the importance of nasal obstruction. I think the tricky thing sometimes is that patients will certainly not volunteer that they have nasal obstruction, and even when you specifically ask them, they'll say, no, I breathe fine through my nose, but you might look inside and that might not be the obvious case. And so people who've had nasal obstruction for such a long time often can't identify it, or even that sometimes the nasal obstruction is quite subtle or only nocturnal, only at